everyone. This webinar on the basics of rate setting for family-run organizations is sponsored by the Technical Assistance Network for Children's Behavioral Health, otherwise known as the TA Network. The TA Network is a partnership with 3 other universities and 7 organizations that you see listed here, and the TA Network provides technical assistance to the Child, Adolescent, and Family branch of SAMHSA's Center for Mental Health Services and to grantees of the Children's Mental Health Initiative across the nation to support states and communities and to expand and sustain their systems of care for children, youth, and young adults and their families. This particular webinar is presented by the Family-Run Executive Director Leadership Association, or FREDLA. This is a new organization created by executive directors of family-run organizations and dedicated to building leadership and organizational capacity of family-run organizations. This webinar is the second in a series on family-run organizations becoming Medicaid providers. The first webinar was held on April 1st and focused on the many aspects of becoming a Medicaid provider that family-run organizations must consider. That webinar is based on a publication called Becoming a Medicaid Provider of Family and Youth Peer Support that was published in February 2014 by the Center for Healthcare Strategies. It's available on both the FREDLA website as well as the CHCS website and probably the Institute website. You shouldn't have a hard time finding it. But a piece of that was discussed in our first webinar was the issue of financing. And you can't talk about financing without talking about rate setting. So we were able to harness 2 truly experts in the field of financing for children's mental health services. Our presenters today are Sheila Pyries. Sheila is a founding partner of the Human Service Collaborative of Washington, D.C., a policy and technical assistance group specializing in child and family services. Sheila has over 30 years experience in national, state, and local government and nonprofit agencies serving children, youth, and families at risk. She has held senior staff positions in the U.S. House of Representatives, U.S. Department of Health, Education, and Welfare, and the Carter White House. She co-chaired the Children's Mental Health and Substance Abuse Committee of President Clinton's Task Force on Healthcare Reform and co-authored the Children's Brief and Policy Recommendation for President Bush's New Freedom Mental Health Commission. If you're counting, that's 3 presidents. She now serves as a senior consultant to the Children in Managed Care Program at the Center for Healthcare Strategies. Our second presenter is Deborah Harberger, who is the Director of Fiscal Strategy at the Institute for Innovation and Implementation at the University of Maryland School of Social Work. In her current role, she works with states, local communities, and individual programs to identify sustainable financing mechanisms to support community-based services and supports. Deborah's interests and expertise include writing Medicaid state plans, who else do you know that likes that, drafting regulations, financing systems of care for children with intensive needs, policy analysis, public, child, and family serving systems, and interagency partnerships. I have had the privilege of knowing both of these women for many years and can tell you they are 20 times smarter than I could ever be. But the best part of their smartness is that they can make it easy for other people, like me, to understand. And my name is Jane Walker. I'm the Executive Director of FREDLA. But prior to taking the position with FREDLA, I was the Executive Director of a statewide family organization for 14 years. And during that time, our state participated in a psychiatric residential treatment facility, or PRTF waiver. That meant that our family organization could begin billing for peer support in wraparound through Medicaid. Previously, we had been doing peer support in wraparound through a grant, and our staff were paid through the grant. I do not think any of us comprehended all that would entail when we no longer were paid through a grant, but instead through a fee-for-service rate structure. You can see me white-knuckled right there. Our rate was a maximum minimum of $50 per face-to-face per day. Let me repeat, our rate was a maximum minimum $50 per face-to-face per day. All I saw was a big $50. Well, I was paying my staff at a rate of $18 per hour. I thought I was golden. 50 minus 18 is 32. I was going to make money on this deal, except that I didn't. And in fact, it almost sunk our ship. For 4 years, we ran a significant deficit. I didn't realize all that had to be factored into the rate to make us break even, let alone come out ahead. After the first 6 months, when I saw us going deeper and deeper into the red, we called in an expert who helped us to look at our costs, and it quickly became apparent that the rate could never cover our costs. So it's critical that family organizations understand the basics of rate setting. Most likely, you will not be called by your state Medicaid office and asked, how much would you like us to pay you? But you could be asked, and hopefully you will be asked, what are your real costs? And that is what, as a result of today's webinar, you should be able to answer that question. So with no further comment, it is my pleasure to turn the webinar over to Sheila Pyries.
Thanks very much, Jane, and good afternoon, everyone. And Jane, thank you for that very gracious. What Jane didn't say is that I have certainly learned as much from Jane over the years, over these many years, than I'm sure she has learned from me. And I also want to say that she did not fall off that cliff. She climbed over it eventually with a lot of persistence. So to do, because Deborah is really going to provide a lot of the nuts and bolts about building a rate, I'm going to provide kind of a framework to kind of set her up. So if we go to the next slide, as all of the activities that are involved in providing a service or support, let's say peer support, all of those activities translate to a cost for the provider of that service or support. And that's really the first task, is to think about all of the activities and create costs, attach costs to all of them so that you can come up with a total cost. That may not be what Medicaid will cover. They may only cover part of your costs. But that then becomes a negotiating process with certainly if you're at the beginning stages of talking with Medicaid about covering peer support, you want to be very well armed with data on what your true costs are for providing this service. And then it becomes a negotiation. If Medicaid already is providing peer support and the rate is inadequate, again, rates can always be changed, and to go in and armed with data to have those conversations with Medicaid. So let's take a look at some of the issues here. Another factor is that the Medicaid service definition is important to what Medicaid will pay. So think of the Medicaid service definition as really the description of what are allowable activities in effect. So taking peer support, does the service definition that is either in place or is developing, does it cover things like telephone time, or do you have to have face-to-face contacts and they'll only pay for face-to-face? Does it cover transportation? And if it does it cover meals and lodging or just gas? documentation time, because now you're operating in a Medicaid billable services environment where you have to document what you did, and documentation takes time, and it's an activity, and it equals a cost. Time also equals money, so think about what you spend time on. That's another way of what your costs are. Supervision and coaching. Does the definition encompass that, or is that outside of the definition? Training. Are there required trainings that have to be done? Is that included within the rate, or is that outside of it? There are also around how many hours of service can be provided per day, per week, per month, per year. So for example, if you have a full-time peer partner, but they can only provide up to 4 hours a day, you're not paid for all that time if you're employing that person full-time. And then what are the requirements for who can provide the service? And does that have implications for retraining or training that you may have to do? And is certification required? Those are a number of issues around the service definition and why the service definition is so important. Steps to take here are to understand all of the activities involved in providing a given service, cost them out. For example, estimate how many hours a week a peer support provider, filling out required documentation forms, and then multiply that by the rate per hour. Know what activities will allow, what Medicaid activities Medicaid will allow, and what Medicaid is proposing to pay or is already paying, cost to what Medicaid is paying or is proposing. There are also implications for how Medicaid pays, which is the next slide. How payment is structured, no, go back to the previous slide. Is it structured in 15-minute billing increments, for example? Is it a monthly or daily case rate? So you're receiving X dollars per child per month, which can be much more flexible than a 15-minute billing system. Is it per session with a minimum time established for a session? Is there a yearly cap on what can be billed? And then very important is whether payment is going to be through a Medicaid managed care organization or a behavioral organization. And if so, how much is that managed care organization going to pay? Because sometimes states will either require or allow the managed care entity to cover peer support, but they won't specify how much the managed care entity will. So then that again becomes a negotiation with the managed care organization and the importance of demonstrating your full costs to the MCO so that you can have that negotiation, the discussion around what they'll pay. And finally, to gather data about rates, states and communities, and how the rates are structured. We did the resource, the Center for Healthcare Strategies did a resource on Medicaid financing for family and youth peer support, and it's a matrix that shows which states are covering family and youth peer support either as a state plan service or as a waiver service, what they're paying for that service, whether it's on a 15-minute billing increment or it's a daily rate, who can provide it, whether there are certification criteria, what billing codes are being used. And I put the link in as so that you can access through the Center for Healthcare Strategies. So these are sort of a larger framework to now transition to Deborah's talking about getting down into the weeds and actually giving you an example of how to build a rate. So on that note, I'm going to turn it over to you, Deborah.
Thank you. And you heard from Jane's bio, I do enjoy things like state plans and regulations. And as Sheila said, we're going to get into the weeds, so you've all been given fair warning. We're going to really talk about creating a rate for peer support. And this is in the instance that the Medicaid agency does come to you, or you're working with your partners in state government or in a center of excellence, and they say, we have this opportunity, what should the rate be? And then, as Sheila talked about, and Jane, it will help you to think about what rate will cover your costs. But we're going to go through this step by step. So the first question is, how do I actually design a rate? Sheila already outlined several of the steps. You have to first think about which of the activities do you provide and which of those are billable. Peer support partner to supervisor ratio. What is your personnel structure? Not necessarily including your executive management, like the executive director of your agency, or maybe a financial vice president or something like that, but your personnel structure and administrators and administrative assistants. Figure out what is your overhead, what are your administrative and your fixed costs, and then think about the billing structure and whether you have any flexibility in it. And then it's time to start playing with the numbers, and we're going to go through all of this in detail. So before we get into it, though, there's several things to keep in mind. One is that what we're about to do is a rate for a peer support partner within an organization. So if you are a standalone peer support partner, the construct for this rate, the cost will be lower. The rate structure we're going to walk through assumes that the peer support partner is within a family support organization or other agency structure. And as you have more peer support providers or other individuals within the agency providing billable services, agency that also has therapists doing mental health services, you can achieve a certain economy of scale that lets you spread your infrastructure and overhead costs across more direct staff. So that will play into your calculations that we're going to go through. And ultimately, you want to be practical and realistic. You want to strive for the best possible rate, the most appropriate rate, and a reasonable rate. But you do need to be mindful of what your state pays and what your state pays other providers with similar qualifications. Sometimes if you take the time to see what individuals are paid who have a degree or a PhD or are in a large hospital system or outpatient mental health clinic, and you see the rate that you've come up with is actually higher than what Medicaid pays in your state for those services, you'll realize that you have to make some adjustments. And I want to go back to what Jane was saying about what they realized, how much they could bill, and also note that something that was said in the April webinar, I think the other Jane from Arizona said this, and it's in the CHCS document too, that it's really important that you have diversified funding so that you have enough revenue to help cover your, recognizing that the actual number of children and families that you serve will fluctuate. So all of that being said, oops, sorry, wrong way. We're going to build your cost, your rate, based upon the cost of employing one full-time equivalent peer support partner. In terms of that peer support partner and all of the costs that surround him or her to be able to do this work. So the first thing to do is to figure out your total billable time. And that means the total amount of time that you have for things that are allowable costs you can actually bill Medicaid for. So your total billable time equals the total work hours in the year minus all of your non-billable activities. And then to get the percent billable, you're just dividing your total billable hours by the total work hours in the year, and of hours that are billable. And that's helpful because then you have a sense of how your staff are spending their time and how much revenue you can expect, and you can track whether you're achieving the expected billable rate. So your basic assumptions are going to vary based on in your state. So a lot of these assumptions that I'm giving you are based on work we did in Maryland to prepare for our 1915I state plan amendment and for our peer support service. And we were very fortunate that Jane really worked with us to help think through what her organization provides are for her organization, and we took some look at some national literature and national averages. And basically what we see is that there's around 20 days of sick, holiday, and vacation leave per year when you factor in all the federal holidays and typical vacation leave. In Maryland, we have the Wraparound Practitioner Certificate Program, and that's for peer support partners as well. And that comes out to around 16 days of training per year when you also include your in-house training that would go on inside of the organization. So you subtract all of that off, and you create 44.8 work weeks instead of the 52 in a calendar. And you multiply it by 8-hour days. We can all assume that we do 8-hour days, even though many of us do more. And you come up with a number of work hours. So organize your calculation. So this is an example of it in sort of an Excel spreadsheet. And you see at the top that 2,080 hours is if you had an 8-hour day times 260 days, so a 5-day work week, off the other hours, and you're at 1,792. So then we're going to start figuring out what else is not billable. So you need to figure out your travel and how much time you're spending traveling. And that is going to depend on the geographic size of your service area and whether you have telephonic peer-to-peer support. If you can't bill for telephonic peer-to-peer support, then you're going to need to do more face-to-face, which is going to increase your travel time and cost. Your documentation costs are going to also depend on a few different variables. You can bill for documentation that's not done with the client and what counts and what doesn't count. If you guys receive Open Minds, there was a recent article about collaborative documentation and what that means and where that's able to be reimbursed by Medicaid. But basically, you have to think about what's allowed. We made what I believe to be a valiant attempt to include documentation in our rate for Maryland and failed. But so you do need to make sure that you're incorporating that, and it's probably a safe assumption that you won't be able to bill for much of your documentation time. You have to think about your personnel structure. Do you have administrative support for your peer support partners? If there are individuals who can assist you with documentation, that's going to take some of the documentation burden off of the peer support providers. You also have to think about what is required by your Medicaid agency, whoever else contracts with you, and what are the documentation requirements. Is there a required management information system? Is it usable? Is it user-friendly? And what does that amount of time, does that actually save you time? Do you end up having to double enter things? That's all worth considering as you track this out. Sheila said time is money. So this is one example of how you might come up with 10 hours a week of travel, not with the client with you, and that you might have document with the client for 1 hour a day. And the reason it's only 1 hour a day is, as you'll see, administrative support. So that's a number that's going to fluctuate. And you can see that just by doing basic subtraction, we get to a total projected billable time of 1,092 hours. Again, this is not a hard and fast number. This is going to depend on your organization. What to do is to figure out what are your personnel costs. So as we said before, we're going to focus on the peer support partner. And you're going to assume one full-time peer support partner. What are the costs for that person? If you know for a fact that you are never going to have more than a half partner, or you know for a fact you're going to have a different volume, you can use those figures. But for the purpose of constructing the rate, I did it around a single peer support provider because that is the individual for whom your organization will be billing for their services. Ideally, use actual costs from similar organizations. If you don't have actual costs, if you can, utilize living or housing wages and profiles of average cost in your geographic area. What you'll see is that a housing wage is going to push your rate way up, but it may give you a threshold for starting. I know that it helped us locations in Maryland, because we are able to say that these rates are based on actual salaries and also on rates that people can actually afford to live. So that's a good starting place. You're not necessarily going to be fully successful, but it's good to start there. To calculate the annual salary cost for positions other than the peer support partner, because remember, we're doing a full-time equivalent peer support partner. All the other folks, you're using the annual salary times the percent of a full-time person per peer support. So in this case, we've created a salary for these different individuals. And what you can see is that you have 0.1 FTE. Percent of a family support partner's time is being spent supervising the family support partner, and that's because we have a 1 to 10 ratio here. Then you have an administrative assistant. You have 0.15 FTE for an administrative assistant. So that's how many administrators you have per, you can sort of work out then how many peer support partners, family support partners they're supporting. And you can see that each family support partner only has a small percent of a billing support specialist and an administrator's time. So then you see that the salary cost is just a multiplication. It's multiplying the annual salary by the percent FTE. And many of you do this work all the time, and so this is very basic for you, but it can get overwhelming when you try to throw it all into a budget. So we're breaking it apart piece by piece. Your fringe benefits, hopefully you already know what your fringe benefits cost, what comprise your fringe benefits, and so you want to make sure you're including all of them. If you're a really big organization, you might have things like employee assistance, wellness programs, tuition remission, all those things. Use actual costs if you have them. If not, sometimes we use a number around 25%. If you offer a lot of benefits, maybe it's more like 30 to 40%. And those are calculated as a percent of salary cost. Most organizations use a standard number for all employees, regardless of which benefit. So for every single person, you would just be budgeting, say, 30%. You wouldn't be having it fluctuate based on the actual benefits they take, because it is just a budget and a projection. So here's an example of sample personnel costs when you include fringe benefits at 25%. And again, just multiplied out across. So then, and we'll come back to how this all fits together, but your other costs are everything else. So you have your rent or office space costs, and you want to try to break it out to per FTE per year. You should have a sense of what are your communications costs, including cell phones, internet. Your mileage costs, again, you're going back to your total estimated miles, and that's going to probably relate to the total estimated travel time that you've already come up with. Unless you have a rate for the reimbursement of mileage, typically we would recommend that you go with the U.S. General Services Administration, the GSA rate for operation of a privately owned vehicle, which right now is, I believe, 56 cents per mile. If you have agency cars available, you have to use a slightly different rate. And actually, the GSA does offer a rate for agency cars within the federal government, what that reimbursement rate is. So that would be a slightly different calculation. And then, of course, you have your office supplies and maintenance. What does it cost you to print materials, to photocopy, your fax machine, postage, all of those things, pens, paper, all of that. If you have a management information system that has user fees, that should be factored in. And then if you have insurance, general liability insurance, professional liability, those are all costs that you want to try and factor in. So except for mileage, when we calculate out these costs, we're going to base the cost on the number of FTEs per peer support partner. So in this case, we have a total of 1.35 FTEs per peer support partner. So then we're going to come up with our total direct costs and our modified total direct costs. And you'll see in a moment, I'm sorry I forgot to include this slide earlier, but you'll see the full slide a little bit later on that includes their costs. But total direct costs are all of your personnel costs plus all of your other costs. Your modified total direct costs are typically all direct costs minus rent costs. And that's going to depend on the rules within your organization, the rules within your state, whether you're using a modified total and if that's how you're calculating it. But that is relevant for your indirect cost. The first question is, do you have a federally approved indirect cost rate agreement? You may not if you haven't had a federal grant or if it hasn't been required of you. So if not, the second question is, what's the average indirect cost rate that your Medicaid office typically approves? We were told in Maryland that it's typically an average of 7%. So in the absence of a federally approved rate, we didn't have a lot of leg to stand on to use something other than the 7%. If you have the luxury of creating one, you want to consider the other included in any other line item, including your executive administration. And as I noted, typically indirect costs are calculated off of the modified total direct costs. In some situations, it's based on salary or personnel costs only. And again, this is an instance where you're going to want to find is the expectation in your state and from your Medicaid agency. So to calculate indirect costs, it's your modified total direct cost times indirect cost rate. And then your total cost per family support partner is direct costs plus indirect costs. So here's the sample that I was referring to. This is just an example, of course, but here you see the personnel costs are up here, and then down here are your other costs. So in this case, we have rent at $200 per month per FTE. We have cell phone communications at $110 a month. Mileage, in this case, 10,500 miles, which sounded like a lot until I thought about how many is that per week, and it actually wasn't so much. Office supplies and maintenance, management information system, insurance, and then indirect costs. So you can see in this case, paying the family support partner a salary of just under $40,000. When you add in his or her fringe benefits, you're at almost $50,000. And when you actually calculate all of the costs to have a peer support partner, a family support partner doing this work, in this instance, it's right around $87,000, $88,000 a year. So what do we do next to set the rate? If you're working on an hourly rate, you're going to take your total cost for one peer support partner, that $87,000, $88,000 number, and divide it by the total billable hours that you already came up with. If you're doing a 15-minute rate, you're going to do the same thing, but then divide it by 4. So here's a sample rate. You have a total projected billable time of 1,092 hours. Your total cost is $87,000. So that creates an hourly rate of $80 an hour, $40 per 30 minute, or $20 per 15 minute. Now you've got to be ready to negotiate. This is a pretty high rate, and you are not very likely to get this, but it's a reasonable rate, and it's based on actual costs. So it's a good place to start the negotiations because it's based on something. You can try to negotiate a telephonic rate, and we'll talk about what is in existence in Maryland, but we, at least in our proposed application to CMS, we did include a telephonic rate, and it's my understanding that Arkansas is also considering proposing that to the federal government too. And we proposed half of the standard rate. And the reason we tried to do that is we felt like it would be of more benefit to the family support organizations to be able to telephonic and not incur as many travel costs. And for the same reason, we picked the 15-minute billing increment, because we knew we couldn't get a monthly rate or even a weekly rate. And so we wanted to ensure that the family support organizations could maximize their billing. by having these large increments of time, it's difficult to maximize the billing because you don't know how much a given family is going to need on a given day. And I think that was just one of the many trials that Jane and the Maryland Coalition went through trying to figure out how to do this when it was a 3-hour block. It was a minimum of 1 hour, maximum of 3 hours, but it was a flat $50. And so if a family needed 8 hours or if the family needed, 45 minutes, it was the same rate either way. And so they were really stuck. So a 15-minute rate, if you can't get a larger case rate, might be of benefit. One note is if you are creating a larger rate, you're not going to want to just multiply the hourly rate because that rate factors in non-billable time, and it doesn't consider how many families are on the caseload. So there's some tweaks to the calculation you'll want to make, or else your rate will get way too high. So now it's time for our reality. In terms of states that have Medicaid rates, it's really very variable. Alaska has a pretty good rate at $17 for 15 minutes. And Arizona, you can see Arkansas had been $4.25. We worked with Arkansas a little bit on the fly, and I don't know if there's anyone from Arkansas on the phone, but they seem to have some success in using this rate model that we just walked through and getting some agreement to use to get a higher rate. And I don't know that it's gone to CMS yet, but $15.23 a minute rate and a 15-minute rate for telephonic. So that's very exciting. One thing you'll note is that there are a lot of states that have this, but they have it through a 1915C PRTF demonstration waiver. And that is not a structure that's available to states right now to utilize for the PRTF population. So these waivers are going away. So we'll see if they make it into other aspects of the state plans or other waivers. And sometimes you do see slightly higher rates in a waiver than in a regular state plan service because you can control the number of individuals receiving the service. But you do see Georgia has a really nice rate that's paid to the organization at $20.78 per 15 minutes. So that's over $80 an hour. And so there's a few different rates, and those all come from the document that indicated. Okay, so here's Maryland's reality check. You can see that under our demonstration waiver, as Jane was referring to, it was $50 a day for up to 3 hours. If you try to convert that into an hourly equivalent, it's $16 an hour. But it wasn't like they could bill for an hourly rate. It was still really tough. The state plan amendment that was submitted to CMS in March had rates that were ultimately negotiated to what you see up here, which converts to $63 an hour or $31 an hour if it's telephonic. So maybe not perfect, but a whole lot better than it was. And as a point of comparison, if you look at our state regulations based on our state plan, an individual therapy provided by an outpatient mental health clinic, which always has higher rates because they're a large organization that has a lot of requirements, including having psychiatrists now. Their rate for individual therapy translates to $118 an hour. And individual therapy provided by another mental health professional, which may or may not be within an organization, but it's paid to the individual, translates to $69, $70 an hour. Too far off from that individual rate, but it certainly lags quite a bit behind an outpatient mental health clinic. So that is the reality check. So the question is, what if you need to make your organization's budget fit an existing rate and you don't get to help design it? If you already have that rate and you need to figure out your budget, you just apply the method backwards. Start with the rate and calculate your total anticipated revenue based on billable hours. Break that down into personnel and other costs. The issue of your caseload and the anticipated number of families served is more relevant if you're working on a daily, weekly, or monthly rate, because then you have to figure out your volume. If you're working with 15-minute, 30-minute, or even hourly rates, you can work more around the concept of billable hours as the foundation. So that's all I have, actually. to make sure that you knew that we'd be having office hours through TA Network focus on this topic. Jane and I will be joined by Diana Simons from the Center for Healthcare Strategies, one of our TA Network core partners, and she was on the April webinar to answer questions about Medicaid, being a Medicaid peer support provider. And we did have the link here for if you're not receiving the TA telegram. And so now we're going to, I think, open it up to questions. Jane or Sheila, did you have anything you want to add before we open up the lines?
Thank you, Deborah. That was very comprehensive. And I see that you have made a note here that the slides and the recording are going to be available next week, because I think probably people have to pore over some of this information. So, Deborah, they're going to be on the Institute, or how will they get them?
We will send them out email to anybody who was a participant, and okay. We will make the link available also through the TA telegram.
Okay. All right. So in order to ask a question, are people unmuted, Adam?
I will unmute everybody now.
Phone on mute if you're not asking a question.
Does anyone have a question? See, Deborah, you were so thorough, and Sheila.
Or we put them all to sleep.
I have a question. My name is Patty DiNardo with the Finger Lakes Parent Network, and one of our services that we also provide is respite skill building, and I'm wondering if that's going to play into this at all in addition to the advocacy billing.
Sheila, Deborah, do you know about respite care?
One of the questions is going to be if that's also Medicaid billable service, or if you're trying to roll it all up into one, or if they're two separate rates that you're trying to make available. And if it's two separate rates, I mean, the basic construction that we walk through is the same construction that I use to create all of the rates for Maryland state plan services for the most part. And so with respite, it is a little bit different because you do have to factor in how many children or families you expect to serve. So the caseload does start to come into play a little bit more with respite, particularly if it's overnight. But you would use the same construct.
Thank you.
You know, Jane Collal at the Family Involvement Center in Arizona does bill Medicaid for both peer support and for respite, I believe. So you might want to contact Jane and see what rates they're.
Thank you.
Mm-hmm.
Okay, this is Jane Walker again, and I'm just going to, again, using my own experience, kind of summarize the key points that both Sheila and Deborah made, and that is that the rate is a whole lot more than just dollars. Knowing your costs and personnel costs, but all of the other costs on top of that, including your administrative costs. But then the other key piece, which was the one totally went over my head, was this maximum minimum billing, in that, you know, it had to be face-to-face, which drove our costs up with regard to travel. So if we sent a family support partner out with a family and they had to drive 30 minutes each way, just to start with, that was going to cost us 2 hours of personnel costs plus mileage on top of that. And if they were with a family 1 hour, we were going to get $50. If they were with a family 30 minutes, helping them do something very important like fill out an application for respite care or for school lunch or summer camp or housing, we were not going to collect anything, but we would have to pay our staff our mileage. If we were with a family 3 hours at a court or IEP or emergency room or anywhere else, we were still only going to get paid that $50. And that is where our biggest losses came from, was our inability to, and that still has not changed in Maryland regulation. So being wary not just of what's the hourly rate, but as Sheila said, you know, what can you cover, the training days, the supervision hours, how you build all that in to cover your costs. It was way more than I ever anticipated. And of course, we all got into this because of our kids, not because we had MBA degrees. So I have to say we learned the hard way, but it was having resources like Sheila and Deborah that helped us get through. So any other questions or comments even? Experiences people have had in their own state with rate setting or Medicaid billing. I mean, I guess I'm painting perhaps a worst-case scenario, and I know that in other states it hasn't been that way. So if others have different experiences, please share.
Jane, this is Ann Cuppinger from New York, and you know, I'm thinking about the interplay between these rates and caseloads and case mix.
Yeah.
And wondering, you know, kind of what your experience was with that. You know, I mean, for the purpose of constructing a rate and thinking this through, we're going to assume that people are going to be working with families with a similar case mix in terms of level of need. But obviously they're going to have to think that through, because if the system shifts, then they end up with, for some reason, families who have more significant or emergent needs or whatever. That's going to change, you know, the intensity of time. So I don't really necessarily have a really clear question here, but just any of your thoughts and observations from anybody on that. And because I'm thinking about this per member per month rate as being, you know, probably what, you know, is most flexible and allows the programs to use their judgment and float things up and down based on needs that pop up. So not really a clear question there, but your thoughts on all of that.
You know, if you do go to a per member per month rate, which does give ability that way, you still need to go through the exercise, of course, of figuring out what your costs
Right.
are, so that you can you know, do the math around how many families that would then allow a given peer provider to you know, interact with, to serve. You know, this is Sheila speaking again. I see states where the per member per month rate for a peer provider is sort of reserved for families that do have children with serious behavioral health challenges, you know, very high-risk children. And what a state may do is also provide a contract, a general contract using other monies, not Medicaid, for family advocacy for families that really don't meet that criteria, but where, you know, family support, family advocacy can be really important. So another way of approaching this, or you could do it as a kind of case mix, case rate, or you could do tiered case rates. It just gets into sort of complicating, you know, it gets complicated, and then you need some objective criteria if you're doing, you know, that are, like, for example, a lower per member per month rate for families where challenges are not quite so critical or complex. You have to have some objective criteria for determining, you know, why you would put the family into that tier of opposed to a higher one. From a financial standpoint, the incentive would be to move all the families into the higher rate. So, it's sort of, Jane was, it's like the 50-hour thing that Jane was talking about, and I think this is really run organizations, because a $50 per day rate creates a financial incentive to work fewer hours with a family per day, because as long as you work an hour, you're going to get 50. Why work two, right? But for family it's so values-based, and you're really wanting to do everything you can to help that family, it really sets you up for the kind of cost overruns that Jane was talking about. And then the third point I wanted to raise, that Jane had raised, is around covering telephone time. Sometimes these Medicaid discussions, it's sort of a penny-wise, pound-foolish discussion. Medicaid agencies may feel that if they cover telephone time, that it will become more expensive, it'll become abused, but really it leads to the, it really is, and you can create parameters around, the use of telephone time, or use a lower rate for telephone time, as Deborah talked about Maryland's doing. So, I think sometimes we make all this stuff more complicated than it needs to be when you actually think about sort of logically what's involved and what makes sense for families and as the provider of the service, and then, figure that out and then try to, then translate it to rates and go with Medicaid. But
So this is Jane again, and I wanted to piggyback on what Sheila said in responding to Ann's question about the caseload. We kind of made an assumption that the longer somebody was, now our Medicaid was strictly, it was the PRTF waiver, so it was designed for kids in wraparound, high-intensity kids at risk or meeting residential treatment level of medical necessity criteria. Our assumption was that the longer they were in wraparound, the less intense they became. So in some ways we looked at like what a high-intensity family coming in would require more hours per month, and we estimated for perhaps the first, 2-3 months, and then after that they would step down, and I can't remember what the specific numbers were, but we looked at like then they would go into a different phase as they do in wraparound, and it would become fewer hours per month, and they could be in wraparound in Maryland, depending upon which funding stream they were in, anywhere from 9 months to 2 years. So that if they were, approaching a year or more, that it would be more of a, shall we say, maintenance level. And then we even had to make hard decisions about closing cases. Closing cases could be a whole other webinar. That's tough. You get attached to these families, but we had to look at, we had new families coming in, and we had to, maximize the use of our staff because we didn't have enough money to keep hiring more staff. And B, in reality, had we performed what needed to be done with that family and then close the case. So I think your point about case mix is a very important one to think through. But the other piece that led me to comment on as well is the ebbs and flows of the referrals, and that sometimes they were coming in fast and furiously where you would want to be hiring, 5 more staff, and then, at certain times of the year, things would slow down, and that would pose a different kind of financial hardship. Here you were carrying staff, you didn't want to let them go, you've invested, you've trained, and for example, with our PRTF waiver that ended, and the kids started phasing out of it, and then what do we do? So those are all, business decisions that you have to make that are not easy to make.
I see someone has their hand raised. Is there another question?
Yeah, this is Francis. Oops, I'm echoing. Sorry. This is Francis Purdy, and I'm concerned that you haven't talked about the cost of group work.
So that's a good point. If I'm going to go back a few slides, you see in one place we have Kansas, and you can see right here that Kansas has a group rate that's a fraction of the individual rate. And that is going to depend a lot on how many families you think you're going to serve. But it's usually a smaller number, a lower number, because you're able to bill for multiple families. And so in establishing that, most states have various forms of group services that are made, whether it's family therapy or psychoeducation. There's various group rates. And so I think that the place to start is to see what are the rates that they provide that the state has already allowed for an individual rate, for an individual service, and then what for the same service when provided in a group setting, and you'll figure out what percent that reflects, and then you would want to apply the same percent if the purpose is creating a rate that you think your Medicaid agency will approve. And if there's a reason that you think that your rate is strongly different, for example, you think most you would ever want, let's say, is 3 families, and the structure that's been created by Medicaid assumes more like, 8 or 10 families, that would be a basis for, trying to argue for a higher rate than maybe what would be proposed. But that is all very relevant to how. And we really focused in on peer support in this instance, but I think everything that everyone is saying really does talk about the necessary mix of services and supports and diversification of funding. I think that that's what it comes back to in a lot of ways. And, can you get some grant funding, and can you get some line item agencies, and then can you have this mix of services and supports that have different billing structures so that you can maximize and maybe bill for some sort of psychoeducation service or group activity, even if you can't bill for individual peer support. And then one to note, and I know that Jane and I have talked about this a lot over the years, is typically if you provide a service for free to the general public, you can't then bill Medicaid for it. And so that becomes a struggle with some support groups and other kinds of group activities and classes that you might offer that you've typically offered for free. And so the trick with that is a little bit to figure out who you're charging in reality for that. And are you charging grant funds, and who's actually paying for it? And can you implement a slide for other people so that you can actually create a rate for that other service that you're providing? Or do you not bill Medicaid for that because that's part of your diversification of funding and you have grant funds or a line item to support that? But that's something to keep in mind, is that others will pay you what other contracts you have, and Medicaid never wants to pay more than some other payer.
This is Fran Purdy. The reason I brought it up is in Alaska, we were really able to bill for a lot of the prevention, the parenting, a lot of the group work that had, and we established a sliding fee scale so that we could both bill Medicaid as well as charge Title 4E for those folks in child protection and so on.
Yeah, that's great.
And the other thing to keep in mind is that there is EPSDT billing. So you need to think about the actual rate. And then one last thing that I sent on email is if you could talk a little bit about the anticipation of Medicaid audits, both the reason to have a CQI, an actual staff designated to read notes, and then the anticipatory possible fines for audit exceptions.
This is Jane. That is a very, very, very important point. You know, I think every family organization is very accustomed to dealing with grants and having fiscal audits and having your grantors come in and look at your files and stuff. Nothing like a Medicaid audit that we experienced. And the documentation is critical. That is addressed a little bit in the handbook that we talked about, becoming a Medicaid provider, and it does talk about the importance of, you know, training on documentation and supervision, because indeed a family organization is, you know, doesn't get a pass on anything when it comes to Medicaid in terms of if the documentation's not there, it didn't happen, and if you got paid for it, then you got to reimburse Medicaid back, and it can be a very costly, very serious, problematic issue if the audit doesn't go well. So, good point, Fran. Okay. Well, I think we've hit our hour. It's been, I think, a very productive webinar, and I want to again thank our presenters, Sheila Pyries and Deborah Harberger, and remind you that the publication that we've referred to is available on the CHCS website that Deborah has noted here, and that the slides will be sent out sometime next week along with a link to this recording. So thank you all so much for joining us today. We hope you found it informative.